Welcome to the Healthcare Unfiltered Express, where I conduct short video interviews packed with relevant and timely information that you cannot miss. So sit back and enjoy the show. All right, folks. Well, we have Dr. Yelena Janjigian on the Healthcare Unfiltered Express. Yelena, welcome to the show. Thank you so much for joining me.
Oh, it's an honor. Thanks.
So we're going to simplify what once used to be an easier topic. It became very complex recently. How we treat actually esophageal and GE junction type of tumors and cancers. But maybe quick about just introduce yourself to viewers and listeners.
Sure. I'm a medical oncologist and chief of GI oncology at Memorial Sloan Kettering. And over the past 2 decades, my lab, my translational work, and my clinic has focused on this difficult disease, relatively rare disease in the United States, but that impacts lives of so many individuals globally: gastric and esophageal, adenocarcinoma, but also squamous cell cancer. And yeah, like you said, recently we've had some major breakthroughs, and it's great to be able to offer both targeted and immunotherapies to patients, both in advanced disease, but now early stage cancers.
So let's start with early stage cancers. First of all, it's fair to say that esophageal and GE junction are always treated the same?
Well, it depends on the histology. So I think historically squamous cell patients were lumped in together with adenos of the esophagus and the GE junction. I think it's fair to say that distal esophageal adenocarcinomas and GE junctions are the same. Biologically and from the TCGA perspective and so forth. Squamous cell cancers are completely different, but we'll come back to another podcast to talk about them.
So let's focus on the GE junction and esophageal, and we're going to specifically focus on adenocarcinoma. Before we get going, you have to assure me it's okay for me to keep taking my Prilosec, right? Because sometimes I need to get my heartburn under control.
Well, it's a good question. I think in short, yes, but in long, I would also probably, and what I've done and recommended to my patients is figure out why you have such bad reflux that you need to take Prilosec and modify your diet. And
it's
stop
life.
working.
It's life, Yelena. It's life, let me tell you.
Yeah.
Okay, so let's start with early stage disease. Early stage disease, and help us understand how best to approach esophageal and GE junction tumor. And you were instrumental in recent data that was published in NEJM, but take us through until we get to that paper.
Sure. Well, so fundamentally, I think early stage disease is still advanced disease in our patients. And I think that's what recognizing that this is a systemic illness and you will need to approach the treatment with systemic therapy, with either targeted immunotherapy or even chemotherapy to treat the micrometastasis is what really transformed the field. Once you recognize that even if you present with stage 2 disease, you probably don't have stage 2 disease, you probably have more advanced micrometastasis, which is what ultimately recurs, is what helped us advance the field. In early stage disease, areas that the patients tend to recur in is peritoneum or lymph nodes and obviously other organs. And so important is for staging patients we usually use CT scans, chest, abdomen, pelvis, PET scans, and also laparoscopies. And then it comes together for the disease management team, usually a medical oncologist and the surgeon, to understand whether the tumor is resectable and whether or not the patient is fit to undergo surgery. And that's where the magic happens, this decision together with clinicians and of course the patient and caregivers. Over the last 5 years, we've moved away from radiation completely. And so for the patient as an educated consumer to seek out a center that's high volume, to understand what their surgical options are, but also involve a medical oncologist in their care early on is really the game changer. I think we know that local form of therapy can only go so far, and to do trimodality therapy where 2 forms of local therapy with radiation and surgery are combined is not the way to win this battle, and the systemic control is where the battle is lost and won.
So back when I was in training, we used to actually give radiotherapy either before or neoadjuvant, all that stuff. So that's no longer the case. So now you do systemic chemotherapy before and after?
Right. So there were two phase 3 studies that showed that radiation does not add any survival, right, to standard chemo and surgery. And most patients recur distally. And so, of course, this whole urge to get an R0 resection is very important. But I think if you rush into the surgery and you operate and the patients or the surgeons who operate don't necessarily stage the patient completely, there are situations where an R0 resection is compromised. And I think that's an important factor. What we know is that systemic disease recurrence is so important to control, and that's why combination regimen, usually with a doublet fluoropyrimidine platinum, and now we know that a third drug, docetaxel, or so-called FLOT regimen, is the preferred option. And because patients tolerate chemotherapy before surgery much better, and also because, as you know, Matterhorn showed that immunotherapy improves survival, then doing it in perioperative setting to augment the anti-tumor T-cell response and really help the body's own immune system fight the cancer as the patient is recovering from surgery has been the preferred approach now.
Back in my day, it was ECF when we were actually doing ECF. Okay, so you mentioned Matterhorn. Tell us about this, and congrats on leading this trial and being the first author. But tell us a bit about Matterhorn since you mentioned it.
Right. So epirubicin is out, and I remember the days where unfortunately, also guilty as charged, have used those regimens. And we know that the type of chemo you give is so important. And epirubicin has been compared, ECX, to FLOT and is not good. So FLOT is what everything built on. And the Matterhorn study is the first study globally to test FLOT in patients in 20 countries worldwide. And we did this in a prospective fashion, including gastroesophageal junction tumors and stomach cancer, convincing folks in in Italy and Europe, everywhere in South Korea and Japan, to give folks FLOT. And the good news is people can give it globally. And if you add durvalumab, which is an anti-PD-L1 agent, it improves pathologic complete response rate, disease-free survival, and event-free survival. And it doesn't add much in terms of tox. FLOT chemotherapy obviously is where the most of the toxicity.
Why did you want to add durva? What was the rationale behind adding durva?
Well, so the anti-PD-1 agents such as pembrolizumab and nivolumab obviously have been approved based on our work, such as Checkmate 649 data or Keynote 811 data. We wanted to bring neoadjuvantly it to early stage cancer because we know that early stage cancer has a higher risk of recurrence, even if it's resected. And also we know that the immune system is better at eradicating disease before it's floridly metastatic, right? As in stage 4 disease. Of course, Keynote 585 was looking at pembrolizumab, but the design was quite problematic, and we knew that. And so we convinced, AstraZeneca to do the regimen using FLOT, even though we were a year late to the game. Sometimes being second is not necessarily the worst because that, you could do it better.
You learn. And I was reading the paper in preparation for my talk with you, and there was no overall survival benefit yet. Obviously, ASCO GI is coming soon, and maybe you're not at liberty. It's you submit already
It will be at ESMO, presented in Berlin. In
like 3 weeks. Yeah, I'm gonna
check it out. Yeah,
I'm gonna be there as well. I actually have not looked. Is there? Are you allowed to tell us if there's an overall survival benefit or not? You can't tell us. Okay. Although this will air probably closer to ESMO when it's out. Okay. If you guys listening to this, you gotta check out the work at ESMO. We'll have to find out. It's gonna be consistent.
It's gonna be ESMO.
Maybe briefly, just metastatic disease. What are we doing in metastatic disease right now? For adjuvant therapy, it's FLOT plus durva right now, the standard.
Right.
What's happening?
So Matterhorn FLOT durva is part of the NCCN guidelines, and the universe is adjusting. I think the doctors in the community who used to give just cross regimen, which is carbotaxol radiation, are waking up and they're not doing that. The surgeons, I just came back from a Boston meeting where, presented data to the surgeons, educating everyone. In metastatic disease, we already had Checkmate 649 and other studies, but also in HER2 positive disease, Keynote 811, showing that anti-PD-1 therapy in combination with doublet, 5-FU oxaliplatin, or so-called FOLFOX, improves survival. And we have long-term benefit. We have data we submitted to the upcoming Congress for 5-year survival rates in stage 4 disease. And this is disease where prior to these studies, patients did not live beyond a year. So there is a game changer kind of effect. MSI tumors are extremely rare, only 3% of the patients. And overall PD-L1 expression, maybe high TMB and other factors drives this long-term survival. For HER2 positive disease, which is also a validated biomarker, our study showed that a combination of pembrolizumab, trastuzumab together has even more of a long-term survival effect. Again, augmenting the ADCC that trastuzumab probably has. So now the chapter is open for Claudin because Claudin 18.2 is a validated biomarker with zolbetuximab. There are studies ongoing to see if there's synergy with anti-PD-1 because a lot of these tumors have these co-occurring biomarkers, right? All of the biomarkers in our disease are protein overexpression. So the biomarkers we prioritize are MSI is the first that we see, and HER2 is the second, probably most important for biomarker. PD-L1 overexpression is the third, and then Claudin overexpression is the fourth. And the good news for the first three, you can give chemoimmunotherapy plus this or that. Anti-HER2 is that. And then the TBD biomarker is FGFR2b. You also see data coming out for bemarituzumab, which is a naked antibody with chemo at ESMO. So you will see, and whether or not combination strategies, because there's fight studies that look at combination studies with bemarituzumab plus anti-PD-1. But if you just showed up and doing a quick GI clinic in my clinic, for example, if I ask you a question, always say FOLFOX IO. It's the right answer.
Always the right answer. This is really exciting. Maybe my last question to you, and I know how busy you are, you have to get going, is what's exciting? Like what's coming down the pike? Like what is something that we should look forward to in the next couple of years?
Yeah, so perioperatives is where all the excitement is because it's proof of principle you can cure more patients, especially Matterhorn sort of opened those dams, and a lot of industry partners, but also smaller biotechs from all over the world are now looking at gastroesophageal junction tumors, not just distal gastric cancer, because G-junction tumors are on the rise in patients worldwide. It's in people like you and me who not necessarily did anything wrong or have risk factors. They may not even have long-term Barrett's or reflux or anything like that. The average patient in my clinic is now in their 30s, 40s, not necessarily the 70-year-old.
It's terrible.
So it's just that trend like we see in colon cancer, right? Increasing in patients. In pancreas, we've been seeing that. And I think for some of these biomarkers that are cell surface proteins, we need to figure out how to combine them and strategize on the sequence, right, to cure more patients. But perioperative is one, and in later lines, maybe theranostic agents to use radiotracers and lutetium-like work to try to, because once you become chemotherapy refractory, which our tumors tend to do within a year or 2 years of diagnosis, it's very hard to make any impact on their survival in later lines. So theranostic may be the way to do it.
Dr. Yelena Janjigian, thank you so much for coming on Healthcare Unfiltered Express. Really a pleasure to have you on, and hopefully to see you at ESMO.
Yes, see you soon.
Thank you for listening to this edition of the Healthcare Unfiltered Express. Until next time, take care.